My name is Danish Maslamdoost. I'm the Medical Director of Wellward Regenerative Medicine in Lexington, Kentucky. This is the third lecture in a series that I'm conducting on managing pain and how the overemphasis on opioids have really created more harm than good. If you are a physician and interested in obtaining continuing medical education credit for this, please follow the links below and you'll be able to register for that. This particular lecture is about the CDC Guidelines and what rationale they were used, what rationale was used in drafting them. The CDC Guidelines were composed of it was drafted by a committee of medical experts that included a variety of disciplines from pain to psychiatry, addiction, etc. There were also professional organizations represented, including primary care and specialty organizations. There were state and federal agencies on the board, on the committee, as well as opportunity for public input via a federal registry. There was a rigorous conflict of interest screening, which was in contrast to a lot of other guidelines previously drafted, which did have a lot of industry and special interests. The process was fairly regimented. The first step was that the CDC Advisory Committee on Immunization Practices was used as a model for developing the grading system of how to develop the methodology of reviewing studies and determining what's relevant, etc. They looked at the quality of evidence and graded it on a variety of factors, including the quality of the evidence, balance of benefits and harms, values that were represented, any preferences, and resource allocation. They obtained input from a variety of stakeholders and experts, including the public and peer-reviewed venues. There was also a federally chartered advisory committee that provided input on the recommendations. A review committee was drafted, which was composed of subject matter experts, primary care societies, state agencies, and federal agencies, who then reviewed the data that was accumulated. This data was then made public for public to comment on it via a webinar as well as a federal registry. Then the review went back to the committee who was composed of the National Center for Injury Prevention, the Control Board of Scientific Counselors, and they produced a work group to review the existing data and refine the recommendations, which then went back to the Control Board of Scientific Counselors for review in an in-person meeting and went through public commentary. And then finally, there was a vote which had to be a unanimously approved vote. And it was finally adopted and then disseminated. So you can see it's a pretty arduous and detailed review process. And the questions they examined were fivefold. The first question was to evaluate the effectiveness of opioids and compare it to the effectiveness of other treatment modalities, to look at the harms and adverse effects of opioids, the dosing strategies, the assessing risk in patients and mitigating those risks through various strategies. And then the effect of opioids, whether it's acute use versus chronic use, what impact it has on people. So starting with effectiveness, they looked at a variety of studies, but no study was demonstrated to look at efficacy for greater than 1 year. In fact, most high-quality studies, including randomized controlled trials, were of less than 6-week durations, but were extrapolated as long-term efficacy. As far as harms, they defined a variety of terms, including addiction, dependency, tolerance, and pseudo-addiction. And some of the conversations that ultimately led to the DSM criteria of opioid use disorder were originating from these conversations. There's a lot of variety in interpretation of the terms addiction, dependency, tolerance, pseudo-addiction. But really, what it boils down to is that it's an umbrella problem of opioid use disorder with a subsection of those people demonstrating addiction. And opioid use disorder is a fairly broad umbrella that demonstrates that where people have demonstrated an unsuccessful effort to reduce or control their use, and that opioid use has not improved their outcomes in fulfilling major roles in work and school and home life, where they still have limitations in function because of opioid dependency. The harms were assessed with chronic opioid use and were demonstrated to have a higher risk for abuse and dependency than what is prevalent in the marketing of pharmaceuticals, of opioids. They estimated the prevalence to be somewhere between 3 and 26%, and that the risks go up with a history of substance abuse, younger age for onset of opioid use, depression, and psychotropic medications such as benzodiazepines. They demonstrated harms which were dose-dependent with the risk of fatality, as well as other harms that are not really well represented in lay conversations, but are represented in literature. These include cardiovascular events, endocrinologic events, particularly with suppression, immunologic effects, including in cancer remission, and accidents such as road trauma as a result of opioids. The studies they reviewed looked at dosing strategies, which overall demonstrated long-acting and extended-release medications increased the risk for non-fatal overdose, particularly within the first 2 weeks of use. That long-acting medications did not show a difference in pain or function, therefore equivocal to short-acting or other methods of managing pain. And they had mixed findings regarding methadone, which suggested that the risks vary depending on how the medication is prescribed and in what settings it is being used. This goes back to a notion that providers unfamiliar with the pharmacokinetics of methadone do pose a higher risk when utilizing it because they don't quite understand how to utilize methadone. Very basically, methadone is a 30-hour drug, and the dosing today will affect tomorrow's dosing will stack on top of today's dosing, and so really you don't reach a steady state with it for 4 or 5 days at least. And particularly if you have some variability in its use, that stacking impact could really misfire and cause an inadvertent overdose. Looking at risk mitigation strategies, they did not identify any studies that effectively evaluated risk mitigation strategies. There's a lot of conversations about opioid risk tools like the ORT or SOAP, which is another questionnaire, but there's inconsistency in the reliability of these testing strategies, with limited evidence that any other risk assessment tool actually has any efficacy or validity. And this is concerning because a lot of insurers are now coming back and recommending the use of these tools as a requisite for opioid management, but in reality they have no demonstration of efficacy, and in fact can be misleading and faulty, giving a false sense of security that a patient is appropriate for opioid management when they are not. Long-term use was looked at, and they found that long-term use is associated with initiation for low-risk surgeries and low back pain, meaning that oftentimes when opioids are used in these situations, they do become a chronic, the patient becomes chronically dependent, and this, I'll cover a really good study about this in a little bit. So based on their assessment of these findings in the literature, they developed 12 recommendations, and they broke those down into 3 different categories. The first is when to initiate or when to utilize opioids and when to continue it. The second is when you are using opioids, how do you select which opioid, what dosage, when to follow up, and when to discontinue its use. And then the third being, how do you assess risk and mitigate the harms from opioids? These broke down into 3, 4, and 5 recommendations in each. The overview being that adjuvant treatments ought to be provided first, goals need to be established when initiating opioids, and the risks and benefits need to be addressed in detail. When selecting an opioid and addressing its dosage, follow-up, and when to stop it, the recommendations are to initiate with short-acting opioids, start lower than what you or the patient would perceive as necessary, and then titrate very slowly. Remain conscious of a ceiling of 50 milligrams of morphine equivalent daily dosage. Not that this is a hard ceiling, but that there is evidence that doses higher than this become more risky. It addresses acute pain management, and in contrast with chronic pain management, that acute pain, there's a more liberal role for opioid reliance than in chronic, and that patients do need reevaluation and reexamination of the impact of opioids. In addressing risks and reducing harms, the recommendations list a number of risk factors that need to be assessed. Physician drug monitoring databases need to be utilized when prescribing. Urine drug screens are a tool in mitigating some of the risk. Benzodiazepines and certain other medications ought to be reevaluated if used in the context of opioids. And finally, physicians need to be more knowledgeable and adept at identifying opioid use disorder. So starting with initiation and continuation of opioids, we're going to go into these recommendations in more detail. If a patient walks into the ER with pain in their ankle and the underlying cause is a fracture, the treatment is not to prescribe opioids and just let them walk out the door. It's to do an x-ray and determine what the cause of the pain is and then cast them. As I reviewed in a previous lecture, if all we do for every single ankle pain that walks through or rolls through the ER rather, if we interpret every single ankle pain as just a sprain and we send everybody out with pain medication, we're in essence missing some of the patients who another modality would benefit more. They would benefit more from another modality, and the absence of that modality could actually lead to disability. So adjuvants are a necessary role, have a necessary role prior to the initiation of opioids. That patient needs to have a proper workup and diagnosis, that they ought to be evaluated by physical therapists or pain specialists who can better assess the origin of pain and determine whether conservative modalities would warrant are warranted for prevention of further disabling conditions. Interventional workups are more commonly used as palliative and therapeutic. However, I would argue that they have a stronger role in diagnostics than are currently being utilized. Alternative therapies like massage, chiropractics, um, symptom mitigation are often helpful, given that a large percentage of initial acute onset of pain are self-limiting and repair on their own. And finally, depression needs to be assessed and determined if a patient presenting with pain has a concurrent depression or affective disorder, because physical pain often manifests itself first as an underlying depression. What I tell my patients is that the parts of the brain that control how you respond to an emotional stress or adversity are the same parts of the brain that help you cope with physical distress, such as pain. And if you deplete the resources because of stressors from one system, be it the emotional or physical, it's going to deplete resources for the alternate side, and will amplify the dysfunction of the other side. So for instance, if somebody has had a chronic depression, it's going to deplete the resources available to cope with physical pain. So whatever physical ailment exists is going to be much, much more noticeable and amplified. Pharmacologically, adjuvants that ought to be tried prior to opioids, there's a wide variety of them. Anti-inflammatories, muscle relaxants, these or neuroleptics, these can all be tried for a variety of pain conditions prior to the initiation or onset of opioids. And that if opioids are being considered, then the other steps of the CDC guidelines need to be better utilized. The second part of the initiation is to establish goals. We need to establish realistic expectations from the patient. The goal is not to get them 100% pain-free. In fact, I would say pain is not even the primary goal. It's really functionality. That we need to understand what the body is lacking in order to function, and provide them opportunities to heal, but also have a resource if they get into trouble or have excess of pain. Opioids ought not to be the exit strategy, meaning that it is not the permanent fix. This is not the best strategy to use if you're trying to address something long term. It goes back to the analogy of the ankle. If the ankle is if the ankle hurts, it's not appropriate to just maintain that patient on opioids for life. Rather, we need to understand what are the functions that this person needs to conduct. How do we facilitate those functions in a sustainable manner? And then how do we provide them a resource for acute on chronic pain, meaning an aggravation of their pain from baseline pain. And one strategy we use in our practice is a goal-directed or goal orientation rather than symptom-focused. So just to compare and contrast these two perspectives, if we're looking at a symptom-focused perspective, patients often are fixated on eliminating the pain or at least reducing the pain. Whereas if you shift the attention to function, oftentimes just the attention to functionality becomes a distraction and becomes a resource in coping with the pain. Rather than being focused on the immediate symptom relief, shift the focus towards a goal orientation. If that person is it has some functional limitations, what kind of aspirations or goals need to be adjusted to accommodate some of the limitations, and what can be established as an aspiration so that the patient shows motivation and an intent or directional intent for improvement. There are repetitive patterns of dysfunction, such as catastrophizing thought patterns. Chronic pain patients often express. This is that what I call the woe is me symptoms. The fatigue and the exhaustion that typically comes with dealing with a chronic pain or dealing with the limitations of functionality can become a patterned behavior. And even when the patient has improvement or resolution even of the pain, these repetitive patterns just become a part of their nature. So again, it's shifting the focus away from the repetitive focus on pain and look at more of what the patient aspires to, what possibilities exist, and what avenues can be used to work around the pain. This takes the whole perspective of the medical team becoming rather recruits the patient into the medical team rather than the medical team constantly pushing the patient to improve or to continue to be compliant with exercises or do things to help themselves improve. The patient becomes part of the team and rather becomes the nidus for solutions as opposed to the node for disenchantment. This is very challenging and really does warrant a multimodal perspective on pain that incorporates psychological and therapeutic avenues. It's important to explain the risks and benefits of opioids. As I've mentioned in other lectures, there's a tremendous number of myths when it comes to opioids, a lot of which was created in order to market the medications and dispel some of the hesitation about utilizing the opioids. But much of this was misplaced, and both clinicians and the general population needs to re-examine some of these myths to understand which ones really have been derived from science versus marketing extrapolations. It's important to establish the explicit benefits we anticipate to see and to provide a realistic perspective of the utility of opioids. Reviewing with the patient that there is no good evidence for long-term opioid use, that the illusion of short-term efficacy does not translate to long-term effect. And in fact, most patients who have chronically been on opioids would agree that the medications do not work as well as they did when they were first initiated. This tolerance that develops is not just the tolerance to the medication, but also a rebound effect of the medication that for the period of pharmacokinetic efficacy, while the medication is in the system, patients will derive some analgesia or improvement in pain. But when the medicine wears off, the body rebounds and there's a higher sensitivity to pain that outlasts the duration of action of the medication itself. Some of the side effects of opioids do improve with exposure, but this also is a downside because the beneficial effects also diminish with exposure, chronic exposure, and that there are multiple adverse effects that are not well described, neither in the pharmacologic information provided with the medication, nor in a lot of the marketing or advertisements out there for opioids. So for instance, these are the most common adverse effects that are often discussed: constipation, nausea and vomiting, drowsiness, sedation, itching. And these are actually these slides are adapted from the risk mitigation strategy education that the FDA puts out through the core curriculum. These side effects or adverse effects are not that serious. Most of them tend to decrease as patients utilize these medications, and they also have very fairly straightforward remedies to them, but these remedies are often propositioned by the same agencies that market opioids, which tend to be reflecting further pharmaceutical uses. So, for instance, constipation right now, there are plenty of ads talking about opioid-induced constipation and how there's a medication to remedy that. It doesn't really make sense to continue to chase adverse effects of medications with more medications, but that's essentially what's marketed right now. Antiemetics for nausea and vomiting. In fact, Phenergan is a commonly used antiemetic, but in the addiction world, it is utilized to augment the impact of opioids, particularly with codeine. There's a mixture of Phenergan and codeine that's often used in combination. Drowsiness and sedation tends to improve, but there's controversy as to whether patients ought to drive or not drive or use machinery when taking opioids. Nevertheless, there are plenty of patients who do so. And then itching and pruritus, as well as jerking myoclonus, all have anecdotal treatments, but also are advocated that if you opioid rotate, then these effects may diminish with another opioid. However, there are a lot of unspoken adverse reactions. These are in my opinion, the more serious adverse reactions that don't get as much attention as the common ones. Tolerance, depression, dependency, hyperalgesia. These things, in fact, increase with duration and use, whereas the more common side effects diminish with increasing duration and use. So tolerance, for instance, can develop where patients are less and less responsive to opioids. One of the myths that perpetuates the tolerance is the notion of staying ahead of the pain, that if you allow the pain to get out of control and then try to address it, that it's much more difficult. But this can often be problematic because it will induce more and more tolerance. Depression, all clinicians should have a very low threshold to work this up, because it is very, very common in chronic pain patients, and will augment the impact of whatever physical ailment is causing pain. Patients need to be educated on the signs and symptoms of depression and assessed on a regular basis. They ought to be encouraged to do cardiovascular activities, as this is one of the more first-line treatments of low mood. Physical dependency to opioids, again, increases with dose and duration. It's helpful to teach patients pain coping skills in these situations, because having periodic opioid holidays, or periods where the tendency would be to take pain medication, it's helpful for patients to not do this on certain occasions, just to limit how much the body forms a dependency. This is particularly relevant in scheduled dosing or long-acting opioids, because the dependency tends to form around circadian rhythms. If you take opioids, the first thing you do when you wake up, your physical symptoms of pain are going to be amplified without that first dose. And that for patients who have formed a dependency to opioids and really are challenged to wean, then alternative opioids, particularly agonists-antagonists like buprenorphine or methadone, which has very, very little NMDA antagonistic effect, ought to be considered, since these medications do have a little bit less of the psychoactive dependency impact. Hyperalgesia is the higher sensitivity to pain. that results with chronic opioid use. This is particularly concerning at doses higher than 50 morphine equivalents per day. But I would even argue that it doesn't even take 50 milligrams of morphine equivalents, that regular usage by scheduled using or routine, like 2, 3, 4 times a day dosing, long-acting opioids, all of these will have a hyperalgesic impact because the medication will wear off, and patients often won't allow enough time for that hyperalgesic period to adjust back to normal before redosing. NMDA antagonists like ketamine, dextromethorphan are helpful in these situations because it seems to undo some of that hyperalgesic effect through a variety of receptors, not just the NMDA receptor. The risks of concurrent adjuvant medications ought to be addressed. For instance, benzodiazepines, sedatives, alcohol, all of these can have synergistic effect with opioids to cause an increased risk for overdose or respiratory depression. There are household risks, for instance, teenagers or infants finding medications and either accidentally or intentionally taking them. Explaining that opioids have an impact on not just your neuroanatomy and pain perception, but also other organs, cardiovascular system, the endocrine system, the immunologic system. There are studies that even show regional anesthetic techniques to be superior to general anesthetics in cancer debulking, in that regional anesthesia has shown to have fewer relapses or recurrence of cancer. And the theory behind that is because of the impact opioids have on the immune system while undergoing surgery. Cognitive limitations need to be considered, particularly in the elderly or mentally handicapped. Opioids will affect the cognitive processes, and there's a very strong indication that opioids increase the risk, particularly for older people, in falling and subsequent complications of a fall. I remember at one of the AMA meetings I attended, there is a resolution to exclude nursing homes from the same scrutiny that other clinics are undergoing for opioid use, because the elderly don't have as many options as young people do in addressing pain. I would argue, however, that opioids need to be used sparingly in the elderly because of this fall risk and the complications that are very prevalent or common, both cognitively and coordination with opioid use in the elderly. The rebound effect, I think, is worth explaining to patients that, as I've explained in a different lecture, opioids do indeed provide a period of analgesia, but there's a rebound effect. When that medication wears off, the body becomes more sensitive to any pain stimulus. The analogy I use with patients is if I gave you a piece of chocolate and then gave you an apple slice, the apple slice tastes kind of bland, and that's in large part because the body adjusts for whatever receptor is being occupied. So when it comes to opioids, you get a period of analgesia, but then the body will rebound from that with a period of increased vigilance for pain. And that increased vigilance is really the premise behind why chronic and regular use of opioids will actually augment the perception of pain at baseline, but might have some analgesic effect while the medication is on board. This effect works if you're dealing with an acute pain generator, meaning that you have an acute onset of pain, and so the period of analgesia or reduction in pain overlaps with the period of of increased presence of pain, but that when that acute pain starts to subside and go away, that rebound effect of the opioids is really not relevant because there isn't a source of pain to be amplified. The problem is when you're dealing with chronic opioids and the body does not have enough time to adjust back to baseline from that hyperalgesic period. You're essentially stacking the hyperalgesia of opioids, and so after a period of chronic use, patients will typically live at a higher sensitivity of pain, but will periodically get these short bursts of analgesia or reduction in pain. So the trade-off is essentially live on a daily basis, on a regular basis with more pain, but you get a few hours of improvement when you do take the pain medication. And this is true for all pain. So for instance, I'll see patients who have been chronically on opioids, and then they'll have a new issue like a twisted ankle or broken limb, and they'll request more opioids because the perception is that this is another source of pain, and so it warrants more medication. But the truth is that their new injury could very well be covered by the same level of medication. It's not like the medication is discriminating where it goes. It's going to have an impact on all sources of pain. But really what's going on is that patient has a higher sensitivity or higher awareness of pain. The pain is more sensitive to them because they've been on opioids for a long time. If that same person had never been on opioids, then that new onset of pain may not be as sensitive or as uncomfortable. And sorry, I think of opioids as more maintenance medicine rather than I think of them as more as rescue medicine rather than maintenance medicine, that they don't work as well for just a chronic maintenance process because of this reason. So after discussing the risks and benefits, it's important to incorporate the patient into a sense of shared responsibility over their opioids. There is a lot of crime out there when people in the community are aware of somebody taking opioids. So it's important to advise the patient to keep their medication in a private and secure place, to not use their prescription for other reasons. Like if, for instance, they are using it for low back pain, but now they have an ankle pain, it's not appropriate for them to use their opioids for their ankle pain. They need to get medical attention for that ankle issue. All quote green scripts or controlled substances need to be assessed and addressed, that there are rules and regulations around this. For instance, you don't share any medication that goes out on a green script or a controlled substance script. This is kind of an antiquated slide, since there's now electronic prescribing of controlled substances. It makes it harder for patients to differentiate or understand when a medication is a controlled medication and ought to have higher scrutiny, not to be shared, for instance, to friends or colleagues. That's why it's important for clinicians to emphasize that this medication is a controlled medication and ought not to be shared, ought to be secured, placed in a safe storage, etc. So that's essentially the underpinning of how to initiate a patient, or what to do when you're initiating a patient on opioids. Now, as far as opioid selection, dosing, and ongoing care, we'll go through what some of the considerations for this is. The notion of long-acting versus short-acting especially is relevant in a patient with new onset of pain and new prescription for opioids. if a patient is opioid naive, the recommendation is not to use a long-acting opioid, even if that patient is going to be dealing with pain that's present around the clock. So for instance, somebody who has recently had surgery, the perception is that this person is going to have around the clock pain. And while that may be true to a certain extent, much of that pain is manageable oftentimes to an opioid naive patient. It's the acute aggravations of pain that warrant opioid use. Most pain is not quote unquote around the clock. Most pain has ups and downs and undulations to them, where if somebody has other coping strategies, such as over-the-counter analgesics like anti-inflammatories or acetaminophen, or has training or education in how to cope with pain as far as visualization and relaxation techniques, most of these pains are tolerable. It's when the pain spikes that you have a potential opioid need in an opioid naive person. Now, again, this is very different for an opioid exposed patient, because their pain perception is going to be altered. The constant exposure of a long-acting opioid or extended release opioid actually generates a greater sense of hyperalgesia and tolerance. Plus, there's a greater cost more often than not, because these tend to be branded medications as opposed to the generics that are available. Morphine equivalent daily dosing is a very common acronym in managing pain. It's kind of a conversion for opioids to get a better sense of their potency. But they're only estimates, and the studies that have been used to develop these conversion tables have a lot of variability to them. So generally speaking, the recommendations are, if you are converting from one opioid to another, to reduce that conversion by 30%. This has many reasons. One of them is because of that alteration in the conversion factors, but and to provide a safeguard for inadvertent overdosing. But there's also an opportunity in many of these situations to get patients on a lower overall opioid load and reduce their risks. Whenever they're making these conversions, there often is an acknowledgement from the patient's perspective that there is going to be some ups and downs to this, and that those ups and downs do take some time to adjust to, but that once adjusted, most patients don't really notice a difference, even if the morphine equivalency is up at lower level. The other reason is that there are differences in pharmacokinetics from person to person. There's a lot of genetic testing out there, but I'll say that there hasn't been enough, in my opinion, clinical efficacy demonstration for the genetic testing to really warrant its widespread use. With greater science and knowledge, that might be valuable, but overall, it's at the end of the day, it's still a titration to effect. Methadone is one to take into special consideration because it does have differential pharmacokinetics at low doses versus high doses. The conversion factor goes up at higher doses because of this. And that goes back to that stacking effect that I talked about earlier, how methadone will it's a longer acting drug than the typical dosing strategies. So the doses will stack on top of previous doses. In my practice, I rarely initiate people on doses higher than 10 to 20 milligrams. In fact, I would say most often, if I'm initiating somebody on methadone, it'll be around the 10 milligram, 5 to 10 milligram mark, even if they've been on higher morphine equivalencies. And that if you are titrating methadone, to titrate it much more slowly, like every 3 to 4 days. And I would even argue longer stretches, like 5 to 7 days, to make adjustments to the dosing because of that wash-in period. Fentanyl is another opioid that I'd like to mention because it's not one that I typically utilize. Fentanyl's effect is primarily, or rather, the duration of action is primarily a result of its redistribution as opposed to its metabolism. So, meaning that it's a very lipophilic medication. So when it's dosed, you see a burst of activity, but then it dissipates very quickly, not because the medication is leaving the system, but because it's being absorbed into the adipose tissue. So after a long period of usage, it will also have a stacking effect similar to methadone. I'm not a huge fan of it because I feel like the dosing, uh, uh, the impact of the dosing is that people tend to use more and more and more medication due to this redistribution effect. And so there's a lot of variability in how to dose fentanyl because it also has to do with the person's lean body mass. I think that there are, this is just personal opinion, I think there are better long-acting opioids if you are insistent on using a long-acting. That when opioids are initiated, you want to start at the lowest effective dose. And what does effective dose mean? With my patients I communicate, we're only looking for a 60% or less pain reduction. We're just aiming to get the pain to a level that's a little bit more tolerable than where it is now. But we don't want to get you 100% out of pain. Even though we could, I think that if that's our goal, we're going to actually fall into a cycle of increased hyperalgesia and increased pain. Physicians need to have special consideration for dosing above 50 morphine equivalents, and certainly limit how many patients are exposed to greater than 90 morphine equivalents, particularly for opioid naive patients. Now, if a patient is opioid tolerant, this may be needed to go to a higher level, but a strong recommendation is to taper them below these doses for non-malignant pain. And I'll explain why in just a moment. If opioids are not addressing the pain, it's not necessarily beneficial to go higher. It's not necessarily that higher doses of medications will address pain. There are certain variants of pain that really don't respond well to opioids. For instance, neuropathic pain doesn't really respond well, or if it does, the hyperalgesic effect of the opioids tends to give the patient a sense of more rapid needs for escalation. So their tolerance forms much more rapidly in the context of neuropathic pain. And so this is one of the reasons that these limitations are recommended. The odds ratio of an overdose event, as well as a number of other adverse effects from opioids, increases exponentially as you go to higher and higher doses. The odds ratio is double for patients taking 20 to 40 morphine equivalents on a daily basis, but it's almost tenfold when you get to 100 milligrams of morphine equivalents, and this has been replicated in multiple studies. Most acute pain resolves within 3 days. If not resolves, then is largely diminished after 72-hour course. And this is the rationale behind the more recent push towards limiting how many days of acute opioids are being prescribed. What I typically see in an acute onset of pain is that patients tend to have the most intense period of pain in the first 24 to 72 hours, and that their pain changes in precipitous drops. So after the first 2 to 3 days, they'll see a precipitous drop in their pain, which will then linger for 1 to 3 weeks and then will resolve. And this is a typical course of acute pain that I see, whether it's with trauma or perioperative courses. And when things deviate from this broad course, that's when I think getting a specialist, a pain specialist involved would be helpful to figure out if this is a different variant of pain that isn't going to be responsive to whatever um, treatment modality you're using, or if this is an issue of an acute pain starting to transition into a chronic pain, which oftentimes, if caught early enough, can be mitigated, and that acute pain can be prevented from going into chronic pain. There's a lot of neurodynamic changes or neuroanatomic changes that take place in the context of pain, and if these changes can be preempted or addressed early on, that neuroplasticity and synapse formation can be inhibited, limiting that progression towards chronic pain. I think this is true in a wide variety of fields in medicine, and I challenge you to think about your patients in this context, because uh, many of the perioperative complications, such as post-mastectomy pain or post-thoracotomy pain or post-hernia repair pain, these are all situations in which that neuroplasticity, if addressed early on, would show we would have many fewer patients developing chronic pain. Having pain for greater than or having opioids for greater than 7 days is not advised, because if their pain is not changing in the course of a week or improving in the course of a week, it often reflects an undiagnosed pathology and warrants that workup. Dependency forms fairly quickly. The thought process used to be if you're taking opioids for pain, that dependency and addiction is not going to happen. But really, that's not true. That the onset of dependency spikes at 3 days of use. People will have a much greater risk of staying on opioids if they're continuing to take opioids past 3 days of their first opioid prescription. And that the probability of continuing opioid use is dependent on the how that first prescription is dispensed. So, for instance, long-term use beyond 1 year increases with the number of prescriptions on their first episode of use. And that 6% of those prescribed opioids for more than 1 day will remain on opioids. This increases to 13.5% of the population at 8 days and nearly 30% of the population at greater than 31 days. And 7% of all prescriptions are written as 30-day prescriptions. There's a really good article or study conducted out of University of Michigan that looked at the risk factors or the risk of remaining on opioids 6 months after a surgery. So they looked at a wide variety of surgeries, both minor and major surgeries, and they found that 6% of all of these patients remained on opioids after 6 months. That there is no correlation with the invasiveness of surgery, which the authors conclude is a reflection of more the opioids and the biologics of people in the context of opioids than it is the surgery being conducted. Otherwise, you would expect more invasive or more possibly painful surgeries to have a higher rate of opioid dependency than less invasive surgeries. This is such a high rate of complication that it makes opioid dependency the most common surgical complication among all surgeries. The risk of opioid dependency is higher when 2 prescriptions are provided versus 1 prescription, and that the aggregate dose of the prescription is greater than 400 to 800 milligrams of morphine equivalents versus less than 120 milligram equivalents. This was in opioid naive patients less than 45 years of age. So that warrants regular check-ins. Anytime you initiate a patient on opioids, they really do require routine evaluations because the benefits and harms should become fairly evident within the first few weeks of use. If the patient is demonstrating increased courage for function, then it's a good reason to maintain the opioids. However, I personally caution patients against using their opioids in order to function, meaning if you have to take the pain medication to do something, then we need to re-examine whether it's safe for that person to continue doing that activity. It goes back to utilizing opioids primarily as rescue rather than maintenance medicine. The CDC recommends quarterly evaluations, but I actually argue for more regular evaluations because, for instance, if an elderly patient is taking an opioid and now they have progression in dementia, or if they have an infection which warrants the use of an antibiotic that will change the metabolism of their opioids, or if they're increasingly at risk of falling, these things are risky to, in my opinion, to wait 3 months to evaluate. They need more regular evaluations, even if it's just a check-in to see how that patient is doing, what else is going on in their life, and whether there are any changes in their pain. It also affords an opportunity to challenge the maintenance phase of an opioid, to use it as an opportunity to see if we can get that patient to a lower opioid dosage. And it's not intended as a punitive measure. It's not like this opioids are a dog biscuit to get them to comply with some need, some therapeutic need. It's more intended to try to get them to a lower level of hyper responsiveness to pain, as well as to afford them greater leniency if they have a sentinel event or a need for acute pain management. This has to be, the physician addressing this needs to be conscious of the impact on motivation, that patients may misrepresent their pain, and if they perceive the clinician to be intent on reducing their dosage. So the intent and goals of opioid management need to be reinforced in these opportunities, that reducing your medication is not meant as an adverse event. It's actually something that should show some promise or encouragement, since there are some benefits and advantages to doing so. In tapering medications, that physicians should often attempt tapers if the medication is not being effective, if the patient is not showing any signs of increasing rehab or increasing activity or increasing functionality, that these may be deemed as ineffective uses of opioids and warrant tapering. If there is intolerance to any side effect, for instance, sedation, constipation, nausea, I think these are pretty self-evident that a tapering effort needs to be addressed. And if a physician suspects opioid use disorder or any dependency development, or difficulty in controlling their use, if patients are taking their opioids on a regular basis in increasing frequency, then it may show signs of opioid use disorder, or it may show signs that the patient is falling into that hyperalgesic phase and they're not waiting long enough to to develop to return to a normal pain responsiveness before taking their next dose. Tapering to minimize the symptoms, I recommend doing a slower taper. If at higher doses, you can be a little bit more aggressive. At lower doses, it really does warrant slower tapering. If, for instance, somebody has been maintained on opioids for years, I might do a taper at a slower rate than if they have just recently been initiated. If patients are showing signs of opioid use disorder or difficulty in tapering, and it's deemed clinically important to do so, then it's important to get a mental health practitioner involved so that they can aid in both assessing the dependency versus addiction, as well as to aid in other adjuvant therapeutics like counseling. Opioids have a differential effect between the side effects and immediate analgesia, that at higher doses there's a diminishing benefit, there's a ceiling effect to what opioids can accomplish, but that the adverse effects will actually increase exponentially at higher and higher doses. This needs to be, clinicians need to be conscious of this effect, because it simply goes towards the argument of more is not necessarily better. You're getting diminishing rewards from increasing doses of opioids, but you are also increasing the risks at a much greater rate.
It's actually very difficult, and it's a problem we often have when patients have been started on these medications, that because dependence involves a lot of symptoms that will occur when you try to come off these medications, including a worsening of pain, that it's very hard for patients to come off even if they're not getting good pain relief, or even if they may be better off once they come off.
Anybody who's been on opioids for a long enough period of time knows that you just don't say, you know what, I've had enough of this. I'm not going to do this anymore today. I just won't take my pills tomorrow. Like I won't take my Lipitor tomorrow. That doesn't work. The next day, you're very, very sick if you don't take those pills.
It's a combination of feeling a severe flu-like illness along with very, very intense anxiety, really almost identical to a panic attack. But whereas a panic attack is something that's very brief, most panic attacks last 30 minutes. The anxiety that's experienced in opioid withdrawal is like a prolonged panic attack. So there's this sense of impending doom. People truly feel like they're going to die when they're experiencing opioid withdrawal.
Most people can tolerate the flu for a week. If you think that you could get instant relief from it, though, by just putting some more pills in your mouth, it's pretty hard to tolerate the flu. So in that sense, stopping, well, as Mark Twain once said about smoking, stopping is easy. I've done it hundreds of times.
I've been through 7 operations in my life. Nothing has ever compared to that, what I went through. Nothing.
There are protracted withdrawal symptoms from opiates that have been well described since the 1950s that go on for months, with sleep problems, with appetite problems, metabolic abnormalities.
My body screamed and yelled for a year. I had leg kicks that I didn't understand for a year after. I went to a rehabilitation place in Chicago to try to understand what my body was going through because I was so sick.
PROP is a really good organization that I work with. Some of the people that you just saw were members of PROP. This was an educational video that you can find on YouTube about the adverse effects or the physical dependency effects of opioids. They are more protracted and prolonged than most people perceive them to be. I tell patients that we're trying to taper to lower levels of medications. It's relatively easy to taper to lower doses. It's very, very difficult to go to abstinence and it's even more difficult to maintain a period of abstinence. But generally, I find that if a patient has been abstinent for 6 months or more, the neuroanatomy and physiology does start to normalize. And in some cases, patients really are intolerant of that. So the harms reduction that I do is to just maintain a very low dose or a PRN dose of opioids. Some of these symptoms can be mitigated using clonidine, which not only has antihypertensive effects, but also works on some of the receptors that impact hyperalgesia post-opioid withdrawal. Of course, other analgesics like anti-inflammatories and acetaminophen can be helpful. Neuroleptics like gabapentin, Lyrica, tricyclic antidepressants are all helpful in mitigating some of the withdrawal symptoms when patients are going into abstinence. What I find really interesting is NMDA antagonists like ketamine. These can be very helpful in minimizing some of the opioid tolerant effects on a neuroanatomic level. And there's a lot of research going on in using NMDA antagonists, not only in the perioperative setting for acute management of opioid tolerant patients, but also in patients who have opioid dependency and are working to get off of it. Sorry, that's ketamine. Risk mitigation strategies that the CDC recommends. There are a number of risk factors for overdose, particularly patients who have a substance abuse history or dependency, patients at 50 milligram morphine equivalents or more, as we demonstrated in the previous slide, concurrent benzodiazepines or barbiturates, if they have an affective disorder or other psychiatric disorder, age of onset, young age being higher risk factor, duration of use, longer durations being of higher risk factor, or initiation early onset, at the time of onset is a risk factor. All of these are things that need to be assessed because patients do have sentinel events or new changes in their life. Not only for the fact that as you develop a rapport with the patient, they may be more open about discussing some of their historic risk factors. Special consideration for anybody who has any of the following conditions: any sleep disordered breathing, because opioids will impact central sleep apnea and increase the risks for that. Renal or hepatic insufficiency, because various opioids have different metabolic pathways which would cause accumulation in renal or hepatic patients. Anybody with a substance abuse history really warrants a special consideration. I strongly discourage opioid maintenance for somebody with a history of opioid dependency. In these situations, I typically differentiate between medication management with an addictionologist or a buprenorphine versus pain management, which is looking at really the underlying etiology of pain and how do we address that. Patients with anxiety or depression or other mental health conditions are much higher risk for self-medicating with opioids because it does have a brief euphoric effect, albeit the euphoria does tend to diminish with usage. It can still be misutilized as a mood stabilizer. There are far better mood stabilizers with fewer risks of complications that are more appropriate in these settings. Pregnant patients, approximately 40% of Medicaid patients, women of childbearing age, Medicaid patients are prescribed an opioid, which is a really startlingly high statistic. But patients who have chronic pain and are now pregnant warrant a closer examination of different modalities because of the impact it has on the fetus. And anybody over the age of 65 warrants some special considerations, namely because of the accumulating cognitive effects of opioids in the elderly and the risks of falling as patients age. The CDC recommends considering opioid reversal agents like naloxone for patients at higher risk. One of my arguments is if you're thinking about prescribing naloxone for somebody, then there also needs to be a strong rationale for why opioids are needed, and an even stronger examination of their dosage. Do they really need the level of medication that they're being prescribed, or are they taking this level of medication because it's what they've adapted to? So, assessing risks and addressing harms, risk mitigation, essentially. Most states now have a physician drug monitoring program. These are databases that track patients' opioids or controlled substance prescriptions, and the recommendation is that these need to be queried at the initiation of an opioid to identify patients who have either recently received an opioid or are doctor shopping or diverting or trying to obtain more prescriptions than warranted. And these need to be reviewed every 1 to 3 months. In our practice, we review them at least every 3 months, and for high-risk patients more often. They will often uncover an episode where the patient went to the ER and didn't mention that, or situations where a patient doesn't realize that medication that was prescribed to them is a controlled substance or has synergistic adverse effects with the medications that are being prescribed at our practice. But there is some caveats to this because not all sources of opioids are on physician drug monitoring programs. For a long time, VA or government based hospitals like Federal Medical Center or Prison Hospital, these did not communicate. The dispensaries did not communicate with physician drug monitoring program. I know that in some states this is being addressed. I'm not sure if it's in every state. So if a patient does have some federal health support, special consideration needs to be taken. These also help to give insight on pre-existing controlled substances. Like if a patient has been prescribed a benzodiazepine for a long time, it may warrant further scrutiny if an opioid is being considered. It'll give a better sense of what dosages the patient has been used to seeing, and provide patterns of use. If the patient has a regularity in where they seek their opioids, if they're bouncing from location to location, for instance, or trying different physicians out, it can give indication of opioid use disorder, addiction, or even diversion. This is Kentucky's physician drug monitoring program report. There's some variations with there may be some variations with new reports, but typically it will list the patient's name and some identifiers that will help to confirm this is the same patient that we're talking about, the person requesting it, and information about the medications currently being prescribed to that patient. Kentucky has a morphine equivalency dose calculator that they provide for the physician drug monitoring program, which gives an assessment of essentially how much medication is being prescribed. So I'm going to go through a systematic way that I look at these. I first look at the most recent medications that are being prescribed, and as well as the date that the last prescription was filled. I'll look at the pattern of medication. Has it been consistent? Has it varied? Are they using long-acting and short-acting? Are they only using one formulation? I'll look at the aggregate or the cumulative morphine equivalency. This is calculated, extrapolated from the total prescription averaged out on a daily basis. The graph will give me an indication of the patterns or the levels of medications that were prescribed historically. If there was any overlap with multiple prescriptions, you'll see a spike. If there's a small gap between prescriptions, you'll see a trough. This is often an indication of 30-day scripts being filled, like every 28 days or so. There's going to be a gap in there. I want to see who has prescribed medications. Has it been multiple providers, or has it been a consistent source? Where are they filling it? Are they trying to fill it at multiple different sites, pharmacies, to fly under the radar? Are they going out of state to fill these prescriptions? Some states are now interfacing with Kentucky, but not all states have an interface with each other. There is no national system that will pull in information from everywhere. Are they going all over the state to fill their medications? Are they, again, trying to beat the system in some capacity? And I'll look at their most recent morphine equivalent daily dosage and see what's the division between long-acting and short-acting, how much is being prescribed in each category. Urine drug testing is recommended prior to initiating opioids and at least annually, but it varies depending on what risk factors the patient presents with. The type of test is very relevant because there's a wide cost differential between the different tests, and I'll talk about those in a little bit. And usually when I take a urine test, I'll ask the patient in real time, what do I anticipate seeing from this test? Because a lot of times when patients are withholding information about, for instance, they use marijuana on occasions, having this conversation ahead of time will give the patient a sense that you are trying to establish trust, rather than use this as a haha, I caught you moment. And it does require some degree of conversation regarding the utility of this tool, because there is a lot of stigma around compliance monitoring, around opioids in general, and you don't want to create greater stigma or a sense of judgment that these are just tools in assessing risk factors, that patients may also take medications that they weren't well aware of interactions with opioids, and these can sometimes be uncovered with urine testing. So some of the unexpected results that happen with opioid therapy, with rather urine testing. One of the most common is finding medications that are that the medication being prescribed was not found in the urine. And this can be one of many different reasons. It could be diversion, which is what most people are concerned about in this situation, but it also could be that the patient is not taking their medication on a regular basis. And that's not a bad thing. In fact, it needs to be assessed. Now, if the prescription is written for quantities that do reflect more routine usage, then there may need to be a quantity adjustment in that situation. But it's not necessarily a reason to take a different action with that patient. or rather discharge them from the practice because of non-compliance. However, there are other reasons that urine drug testing is warranted: identifying illegal drugs, finding medications that aren't prescribed to the patient. Um, drugs at levels lower than expected is kind of controversial because people do have different metabolic rates, and these tests are usually um, built around certain cutoffs or thresholds. There are multiple different types of tests. Generally speaking, there are two main categories: immunoassays and uh, mass spectroscopy. The immunoassays come in different variants. Some of them are the disposable cups used at bedside, and some of them are chemistry analyzers that have to be processed through a chemistry analyzing machine. Generally, these are less than 10 panels, because that's really what insurance pays for, and most people aren't going to the lab companies aren't going to waste the resources on more than that. They're qualitative, meaning that they're going to give an indication of presence of medication or absence of medication. Now, there are quantities produced with these immunoassays, but because of the unreliability, those are the amount of medication is not usually the clinically relevant factor. It's just the presence or absence if that threshold was met. There's a limited differentiation. For instance, opioids as a general category, or non-synthetic opioids, fall into the same category. So, for instance, codeine and morphine and hydrocodone will all test positive for the general category of opioids, whereas oxycodone may or may not, just depending on the level of oxycodone found in the body. There are specific tests for oxycodone, for tramadol, buprenorphine, and methadone, separate from the remaining opioids, but the remaining opioids can't be differentiated by an immunoassay screen. There is currently no assay for fentanyl, but I believe there is one in development. There are higher rates of false positive and negative in immunoassays than there are in mass spectroscopy. And there is some level of cross-reactivity with medications, that some will test positive in a different category, giving those false positives and negatives. Now, mass spectroscopy is a more expensive test, but it does identify individual drugs and more specific levels of those drugs in as metabolites in the urine. But there is some caution in using the quantification as interpretations. This is very industry driven. If any lab company comes to your door and says, I'll take your lab urine testing business, they typically aren't doing immunoassays. They're looking for the mass spectroscopy because it is higher reimbursement, higher cost. It is higher cost to set up a mass spectroscopy lab, but it is also a higher revenue stream. With that said, it's not always necessary to get those confirmation tests. That typically a screen is sufficient. I would not recommend the bedside cups, as the sensitivity and specificity is fairly low on those, but the bench-side, the immunoassay chemistry analyzers do a relatively good job and are good for a screening panel that then drives a decision of whether that screen needs to undergo mass spectroscopy for further confirmation of the findings. This has been a major financial boon for many companies and has resulted in a lot of Medicare scrutiny with fraud, with rampant fraud in this industry. So I just recommend, if you are working in this arena and working with a lab company, to really vet them out and see if it's a reputable company. Interpreting the tests, a positive test will demonstrate recent use, but recent use can be anywhere from 1 to 3 days. And for lipid-soluble drugs like fentanyl that I mentioned earlier, the immunoassays will test positive for, or the drug screens will test positive for greater than 1 week. Other medications like marijuana can last even as long as 30 days. Negative results are absence of recent use, but it doesn't necessarily reflect aberrant behavior. While most people are concerned about diversion with an absence of a medication that's typically prescribed, it could also reflect infrequent dosing and administration, and it warrants a conversation with the patient that if the opioid is not necessary all the time, that possibly a reduction in the quantity of opioids should be considered just to reduce the number of pills available to the community. And there are limitations to assessments, to urine toxicology assessment, because of cross-contaminants, adulteration. There's a whole industry around adulterating urine testing. If you ever have time, I encourage you to look it up. It's kind of amusing. Cutoffs, all immunoassays, for instance, will have a cutoff. If medication is present but below that cutoff, it'll be deemed as a negative result. So sometimes it is helpful to look at the numbers and see if there is a trace presence of medication, which may warrant compliance or non-compliance. What's not reflected in urine testing is the exposure time, dose, or frequency of use of medication. So it's very difficult to draw assessments on these measures based on urine testing, and those need to be taken into consideration. There's also metabolites in urine testing. This is one of the more common pathways where codeine is actually a prodrug, and it's metabolized to an active drug of morphine and hydrocodone, which can then metabolize into hydromorphone. Heroin will also metabolize into morphine. So anybody who tests positive for an opioid could be taking any one of these medications. That's why it's sometimes needed to get a confirmation test to identify the exact opioid that is being found in the urine. And they do have some specific tests for individual metabolites. For instance, 6-MAM is a metabolite of heroin, which has its own immunoassay. So finding out if you are going through a toxicology lab, what specific assays are being used for their screening would be helpful. Oxycodone metabolites into oxymorphone, and some of these will be a co-contaminant and test positive for opioids, even though they're two different tests. So again, that's another area that warrants some confirmation testing. In general, CDC recommends avoiding risky adjuvants like benzodiazepines and barbiturates. And generally speaking, in the pain context, these medications were once thought of as decent muscle relaxants. It's really not. They're not good muscle relaxants. Even though they will relax muscles, the adverse effects of benzodiazepines, and particularly concurrent use with opioids, do not justify its use as a muscle relaxant. Generally speaking, for my patients, I recommend muscle relaxants only in the acute setting when you have truly an acute muscle spasms. Outside of that, they really have a very limited role and are not ideal anxiety or sleep medicines. Somas is not as often utilized anymore, simply because it has some synergistic impact on opioids and increases the risks of dependency. Promethazine, I mentioned earlier, is a antiemetic, but in combination with certain opioids, there is an increased effect, psychoactive effect. And neuroleptics like gabapentin, which has recently been classified as a controlled substance rather than a non-controlled medication. This was because there was a lot of synergistic abuse between neuroleptics and opioids. In particular, gabapentin's bioavailability is limited by its gut absorption. So patients who do have addiction have very quickly figured out that if dissolved and injected, that potency or that bioavailability ceiling is no longer an issue, and it can be misused in that capacity. With that said, sorry, it doesn't mean that these medications are absolute contraindications, particularly with neuroleptics, only that there is required some increased vigilance and consideration when considering some of these other medications. Opioid use disorder is the last rung on the CDC recommendations, and it's just an overview of what this diagnosis is. It's essentially when patients are unable to stay off of opioids, or if they have functional impairments in the context of using opioids. I would argue that a lot of opioid dependent patients demonstrate signs of opioid use disorder. For a more robust definition, I would recommend looking at the new DSM description for opioid use disorder. But what's important in our world is to understand that addiction is a subsection of opioid use disorder, that not every patient who has been on opioids and is physically dependent on opioids shows addiction or opioid use disorder, but there is a larger number of people who do have opioid use disorder than people who have addiction. Addiction is more of a behavioral diagnosis that the way I describe it to patients is, if the zombie apocalypse were to hit tomorrow and you knew that somebody had some opioids left in their system, would you eat their brain in order to get their opioid? And essentially, if you have an addiction, then the likelihood is that there aren't any consequences that would prevent you from taking an opioid, but that somebody with an opioid use disorder may have withdrawal symptoms, but not necessarily, and have a desire or a need for more opioids, but would not necessarily endure any consequence in order to get it. Medication management with patients who have opioid use disorder or addiction, it warrants a conversation with either an addictionologist or someone who is more adept at managing addiction. Medications like buprenorphine, which is an agonist-antagonist to opioid receptors, has been very helpful. And while it's controversial if patients need to stay on this for life or can eventually taper off, the studies show that the risks for relapse and remission to behavioral problems that occur with addiction are far less if patients are just maintained on medications. Methadone has mild NMDA antagonism, which does reverse some of the adverse effects of chronic opioid use, like tolerance and dependency. And for that reason, it's been historically a resource for addiction management. Now it seems like the tide is shifting towards favoring buprenorphine. Behavioral therapy is very important for anybody who has either opioid use disorder or addiction, and needs to be incorporated into the treatment modality early rather than later. Just as far as resources for physicians or clinicians who are using opioids for their patients, CDC has a pretty good app which has these guidelines and the rationale with the citations that provide the rationale in the app. There's a morphine dose equivalency calculator that can be very useful. And then there's some resources on motivational interviewing practice or techniques. These are ways to help direct conversations with patients in a therapeutic direction. Generally speaking, one thing I want to leave folks with is that when using opioids for patients, there's a role for acute and palliative use of opioids. I think that in these situations, there's a little bit more liberal use of opioids that's warranted. However, in chronic settings, I think that has a limited yield. So when I talk to patients, I say that this is medication that we want to use for acute on chronic pain, but not really for the chronic component of the pain. In other words, we think of it as rescue medicine rather than maintenance medicine. It's not always easy conversing with patients about opioid use, whether you're talking about acute on chronic or chronic issues. So these are just some recommendations on how to converse with patients. Avoid victimizing the patient. There's a sense of disenfranchisement when you tell the patient that we have to make these changes, or I'm limited on what I can do because of government oversight. Really, it does a disservice to not only that patient, but every other clinician that sees that patient, because it makes their job a whole lot more difficult to try to explain why they're doing the medical decision making that they're making. It's better to attribute it to changes in science and understanding around the medications and changing practice patterns that have evolved, not because of patients who have an addiction, but rather because we see the effects that opioids have on patients even with chronic pain who have every good intention to address their pain in a responsible manner. Try not to get into a negotiation with patient. If they start to negotiate, then just go back to the facts of the matter. It's not a give and take as far as, if I do this, this, and this, does it justify more opioids? We don't want to get into the routine of using opioid quantity as a carrot and stick. Many chronic pain patients will have a catastrophizing thought pattern, this perspective of I'm broken beyond repair, and therefore this is the only salvage. This notion really needs to be challenged. Most patients who I see to some degree have adopted this notion of helplessness, that they're completely incapacitated because of a degenerative process that's going to destroy their lives. And it's sometimes helpful to remind patients that 200 years ago, people dealt with the same physiologic conditions that we do today, but they didn't take opioids on a regular basis, and they still maintain function. So it's realigning the patient's perspective on, rather than on symptom management, to more goal orientation. And again, focusing more on just the facts rather than on the drama, looking at the fact that with or without opioids, there is going to be pain, that we're just simply trying to make the undulations, the ups and downs when it comes to pain management, a little bit more even keeled. And opioids do opposite of that. They do give you some troughs in pain, but they'll also give you spikes because of the hyperalgesia. And that the goal of therapy is to provide a better quality of life, not just today in this moment, but 5 years, 10 years down the road. It's not always the best idea to try to get the maximum pain relief now if it leaves you vulnerable to uncontrolled pain down the road, if God forbid some other pathology or problem develops. And so finally, my last recommendation on patients who present with a new onset of pain, I kind of break these two patients into two categories as far as consideration for what to do. In the opioid naive patient, really the first and foremost is to identify the pain generator. While symptom management of the pain is important, as much as possible, I recommend steering away from initiation of opioids, because especially for the consideration of a greater than 30-day prescription or even a 30-day prescription, because the risks of maintaining that patient on opioids and kind of brushing the pain issue under the carpet becomes really concerning. Patients need to be counseled on typical acute pain time courses, as well as the process by which most pain issues resolve. That's just by natural healing processes that typically take anywhere from 3 days to 2-3 weeks for the bulk of it. All options need to be considered, both uh, for reversible conditions and non-reversible conditions. So for instance, somebody who's presenting with an acute back strain, this is a reversible condition. The patient can probably return back to normal, versus somebody who has a non-reversible issue like a very advanced or progressed degenerative disc that is causing other downstream clinical impact. Some of these things can't be reversed, but it doesn't mean that the patient is out of options. And a good pain specialist or sports medicine doctor, orthopedics, neurosurgeon may have options, even non-surgical options, that can, to some degree, mitigate these symptoms. The focus for opioid naive patients is particularly functional, figuring out what that pain is limiting them from doing and how they can work around that until the body either heals or we can find a different long-term solution. And how do we mitigate some of the symptoms without putting the patient at undue risk long-term? And this doesn't mean complete opioid abstinence, it just means judicious use of opioids. For the opioid tolerant patient who presents with new pain, first consideration is how necessary have the maintenance opioids been and how helpful are they? Is it feasible to wean the patient to an infrequent use of medications? Because because new onset of pain is going to be amplified because of the opioids, and if the patient was on fewer opioids to begin with, that new pain may not be as clinically relevant. Now, in the acute setting, this is not necessarily feasible or realistic, but it is a consideration once the acute phase has passed. For opioid tolerant patients, we want to mitigate their risks, and particularly risks of not only overdose, but also long-term adverse effects of opioids. Maximize their function by shifting their focus away from symptom management and more towards functional management. And then finally, do compliance monitoring to evaluate for safe utilization of opioids, but also to try to rule out any unexpected or inadvertent risks. So that provides kind of a summary slide as to how to interpret the CDC guidelines. And while I know that some of these are controversial in the medical community, there is a lot of evidence behind these recommendations, and considering that evidence with an open mind that puts into question a lot of the passed down or anecdotal beliefs that have developed around opioids can be very helpful in addressing the opioid epidemic today and going forward. This concludes this lecture. There is one other lecture in this lecture series to get the full Kentucky has a requisite for 4.5 hours of CME credit in opioids and addiction management. If you are interested in the other lectures, whether for CME credit or for just personal interest, please follow the links below. Thank you.